Bismillah ar-Rahman ar-Rahim, the retina and choroid. Uh, we are going to discuss acquired diseases of the retina and choroid. Uh, Symptoms of retinal diseases will include symptoms related to macular dysfunction, which is the central part of the retina. The macula is, and it contains the fovea, which is responsible for the very fine resolution of vision. The patient may complain of three symptoms, one of three symptoms like blurred vision, number one, blurred central vision. Number two, distortion of vision, which is metamorphopsia in the form of reduction of size of the image, micropsia, or enlargement of the size of the image, macropsia, or distortion of the size of the shape of the image due to compression or stretching of the photoreceptors on the retinal surface. The third complaint of the patient may be visual field loss or scotoma, loss of part of the visual field if part of the photoreceptor layer becomes covered by blood or destroyed by any disease. Functions related to the peripheral retinal dysfunction, and this will include loss of visual field, constriction of the visual field, and this may be absolute as in branch retinal vein, branch retinal artery occlusion, or relative as in cases of retinal detachment. Absolute, which means there is no vision in this part of visual field. Or relative means that there is some vision and you see like a curtain, the sitara, in this part of visual field. The second complaint of the patient is night vision reduction, which is called night blindness as seen in retinitis pigmentosa. You have a constriction of the peripheral field and loss of night vision. Macular diseases that we are going to discuss include age-related macular degeneration, subretinal neovascular membranes, macular holes, macular membranes, macular edema, macular toxic reactions, and central serous chorioretinopathy. And also we are going to discuss peripheral retinal acquired diseases. Acquired macular diseases, first of all, we are going to discuss the age-related macular degeneration, which is the commonest cause of irreversible visual loss in developed world. The pathogenesis, usually there is lipid product deposition in the Bruch's membrane area arising from the outer segment of photoreceptors due to failure of retinal pigment epithelium to remove this material. And this can be seen as a discrete subretinal yellowish lesions called drusen. So we have the retinal layers, 10 layers, we have the photoreceptor layer, and then we have the retinal pigment epithelium layer. The outermost, which is the retinal pigment epithelial layer, is responsible for the integrity and the function of the photoreceptors. Damage of the function of the retinal pigment epithelial layer will result in failure of this layer to remove these lipid products, and the accumulation of these lipid products will result in development of drusen. Drusen deposition under the retinal pigment epithelium, with subsequent atrophy of the retinal pigment epithelium and damage of the overlying photoreceptors. These are hard drusen, whitish, well discrete spots seen in the macular area, and these are the soft drusens, large, ill-defined edges. Also, this is a second type of drusen. Also the pathogenesis of age-related macular degeneration is associated with retinal pigment epithelium and photoreceptor damage secondary to the damage in the function in the retinal pigment epithelium and the development of drusen. There are two types of age-related macular degeneration: dry type, where there is no exudation, exudative type or wet type, where there is development of new vessels from the choroid under the Bruch's membrane and retinal pigment epithelium, and this is called subretinal neovascular membrane, and this membrane will leak and fluid under the retina, and also it may rupture, resulting in hemorrhage, subretinal hemorrhage, intraretinal hemorrhage, even it may produce vitreous hemorrhage. This is a case where there is drusen in the macular area with associated damage of the retinal pigment, overlying retinal pigment epithelium. This is the atrophic type of age-related macular degeneration, where the drusen will coalesce and enlarge, and our retinal pigment epithelium and photoreceptors over these areas of drusen is atrophic, and there is no leakage. So this is the wet type. Here is the this is the dry type. Here is the wet type, where there is development of subretinal neovascular membrane with leakage of fluid and hemorrhage, intraretinal, preretinal, and subretinal. And this hemorrhage will heal by scarring tissue in the macular area with damage of the macular area. Symptoms of these patients يبقى there is dysfunction في الماcular symptoms related to macular dysfunctions اللي حكينا عنها, اللي هي loss of central vision, metamorphopsia, and the last one, which is defective central vision. Signs will include foveal reflex disappearance, absence of foveal reflex, the presence of drusen, and subretinal hemorrhages in exudative type of age-related macular degeneration. Investigations include fluorescein angiography to delineate the subretinal neovascular membrane. The treatment, there is no treatment for non-exudative type or dry type of age-related macular degenerations. So we can provide these patients with low vision aids, magnifiers, telescopes to help them see with their central vision. Argon laser is done if the subretinal membrane is present outside the fovea, so we will do argon laser to damage this membrane and prevent the leakage and the hemorrhage. If the membrane is under the fovea, we may resort to photodynamic therapy, which is a mechanism by which we can obliterate the vessels under the retina without damaging the overlying photoreceptors. We inject a dye, and we call porphyrin-like chemical material, which is activated by non-thermal laser beam, resulting in damage of the blood vessels in the subfoveal membranes, sparing the photoreceptors. The most recent treatment for these age-related macular degenerations, they found that they have high concentrations of vitreal vascular endothelial growth factors. So injection of intravitreal Avastin or other anti-vascular endothelial growth factor drugs will result in regression of these subretinal neovascular membranes. Differential diagnosis, all diseases that have subretinal neovascular membrane will be included in the differential diagnosis of age-related macular degeneration, as these conditions may, like myopia, angioid streaks, where there is cracks in the Bruch's membrane occurring radiating from the optic disc, and they will produce subretinal neovascularization if they go under the fovea. Also, these angioid streaks can be associated with other systemic diseases like Paget's disease, sickle cell disease, and pseudoxanthoma elasticum. Reduction in central vision may occur if the crack passes through the fovea. The next subject is macular holes, which is a well-circumscribed hole occurring in the macular region, destroying the fovea. And usually it results from traction on the vitreous by thin macular traction by the vitreous on the thin macular retina, resulting in loss of central vision, and may be associated with distortion and blurred central vision. Most cases of macular holes are idiopathic, but sometimes it may be associated with trauma, and the treatment usually is vitrectomy to remove the vitreous traction. Macular membranes, these are pre-retinal glial membranes formation in the macular region. It will contract and produce irregularity on the surface of the macula, resulting in metamorphoxia, distortion of vision, and the blurred vision. The treatment is by vitrectomy also. Central serous chorioretinopathy or central serous retinopathy is a localized accumulation of fluid between the retina and the retinal pigment epithelium, separating the area into two layers. And this will result in distortion of the overlying photoreceptor layer with distortion of vision. Usually it results from localized breakdown of normal structure of the retinal pigment epithelium. Usually occurs in young age. Patients have central distortion of vision and blurred vision. Examination will reveal dome-shaped elevation in the region of the retina. Treatment is usually not required as most cases are self-limiting. Sometimes we may find a leaking point if we do fluorescein angiography. If it is outside the foveal or the macular area, we can cauterize this leaking point with argon laser guided by the fluorescein angiography. The next subject is macular edema, which is accumulation of fluid in the retina and in the region of the macula, and this will result in loss of foveal reflex and cystic space development inside the fovea. Fluorescein angiography, which is an investigation, will show leakage of fluorescein into these edematous areas of the macula. Macular edema is usually associated with intraocular surgery, especially complicated cataract surgery, uveitis, retinal vascular diseases as diabetic retinopathy and retinitis pigmentosa. Treatment is usually with steroids, especially if the cause is inflammatory as uveitis. Acetazolamide is helpful in cases of cystoid macular edema associated with retinitis pigmentosa or following intraocular surgery. Prolonged edema will result in development of a macular cyst, and erosion of the upper part of the macular cyst or the surface of the macular cyst will result in development of a lamellar macular hole. The next group of diseases, the toxic maculopathy, and this occurs due to accumulation of drugs in the retinal pigment epithelium causing macular damage. Especially this occurs with drugs like the anti-malarial drugs, chloroquine and hydroxychloroquine, used in the treatment of malaria, but the introduction of these drugs in the treatment of rheumatoid arthritis and chronic connective tissue disorders resulted in the use of these drugs for many years with high concentrations, and so deposition of these drugs in the retinal pigment epithelium. So chloroquine is more toxic than hydroxychloroquine, and patients receiving this treatment should be monitored for macular function and should be monitored with fluorescein angiography and imaging of the macula. Early stages will need no treatment, just discontinuation of the drug will result in reversal of the problem. Late stages of the disease with damage of these retinal pigment epithelial cells becomes associated with irreversible loss of central vision. Phenothiazines also are known of developing this toxic maculopathy, used for prolonged periods to treat psychosis, will result in retinal damage. Tamoxifen, which is used in cases of cancer, may cause this maculopathy. Posterior vitreous detachment, the vitreous gel undergoes degenerative changes in patients in the 50s and 60 years of age, and this degeneration will result in that the vitreous gel will lose its structure and becomes fluid-like with floating collagen and cells inside the vitreous gel. Detachment of this vitreous gel from the retinal surface will produce symptoms like floaters, like flying spots or cobweb inside the vitreous cavity, casting shadows on the retina, and The posterior vitreous detachment will give signs like photopsia, which is flashes of light, and floaters due to the movement of the content of the vitreous with the movement of the eye. And these are called 2F, floaters and flashes, or photopsia. Retinal detachment, which is separation of the neurosensory retina from the retinal pigment epithelium. It has three types. We have rhegmatogenous retinal detachment, where there is a retinal tear that helps the passage of fluid from the vitreous cavity into the subretinal space with detachment of the retina, and this is called rhegmatogenous retinal detachment. Tractional retinal detachment, where there is fibrous tissue development inside the vitreous cavity, and this fibrous tissue contracts and pulls on the retina, resulting in tractional retinal detachment, as in proliferative diabetic retinopathy. Exudative retinal detachment, which occurs due to fluid accumulation in the subretinal space, and this usually occurs in inflammatory conditions as uveitis, and sometimes in cases like toxemia of pregnancy. In rhegmatogenous retinal detachment, there is a retinal tear that usually occurs due to posterior vitreous detachment, usually occurs in patients with peripheral retinal degenerations, as lattice degenerations. High myopia also is a very high risk for rhegmatogenous retinal detachment. Usually, high myopes are affected. Patients undergoing cataract surgery, especially, is complicated cataract surgery and associated with vitreous loss. Patients may have detachment in the fellow eye. Also, it occurs in patients with symptoms of rhegmatogenous retinal detachment include floaters, flashing, and visual field defect. If the detachment involves the macula, the visual acuity, central visual acuity, will markedly drop. So floaters, flashes, and field defect, 3F, are the signs, are the symptoms of the rhegmatogenous retinal detachment. The signs we will examine the fundus and see a pinkish gray membrane undulating in the vitreous cavity, and you can see the tear, retinal tear, pinkish reddish, through which you can see the choroidal vessels. Blood may also be present, as the tear may be associated with vitreous hemorrhage. A pigment may be seen in the vitreous cavity. Operculum or part of the retina detached, leaving a retinal hole, also may be seen floating in the vitreous cavity. Management of retinal detachment: we have an external approach through scleral buckling. بنحزم العين بحزام scleral buckling to make the sclera approach to the detached retina and preserve the function of the retinal cells. Internal approach: we will go through the eye, we remove the vitreous, vitrectomy, and put some internal tamponade to push the retina back to its position adherent to the choroid. We close the break in every case of retinal detachment by cautery or by endolaser or other means, and we put silicone inside the eye, silicone bubble, to produce internal tamponade in cases of vitrectomy. A temporary internal tamponade also can be achieved by injection of gas inside the vitreous cavity at the end of the vitrectomy surgery instead of the silicone oil. The next type of retinal detachment is the tractional retinal detachment, and as we said, it is due to fibrosis in the vitreous cavity following vitreous hemorrhage in proliferative diabetic retinopathy, and usually the treatment of this tractional retinal detachment needs vitrectomy. The next group of diseases are the inherited retinal dystrophies and photoreceptor dystrophies. The first one is retinitis pigmentosa, which is an inherited disorder of the photoreceptors. It may occur solitary or may be associated with number of systemic diseases. Pathogenesis, this disease, degenerative condition affecting the photoreceptors, usually the rods, but also the cones are affected in advanced disease. The inheritance is multifactorial. It may be autosomal recessive, sporadic, autosomal dominant, or X-linked recessive. Severe forms of retinitis pigmentosa have been shown to be due to mutation of a specific gene for rhodopsin. Epidemiology, prevalence about 1 in 4,000, the prevalence of the disease. Symptoms are gradual progressive damage to the peripheral vision of these patients. So we'll have night blindness, visual field defect, constricted visual field, central vision will be damaged at advanced cases. Usually recessive and recessive cases have severe forms more than the dominant cases. The signs, there are 3 signs in typical retinitis pigmentosa, which we see during fundus examination. Peripheral clumps of retinal pigments, bone spicule pigmentation. The second sign is attenuation of the retinal arterioles. The third sign is disc pallor. Patients also may have cataract at an early age if they have retinitis pigmentosa. Also, they may have macular edema. These are pictures representing retinitis pigmentosa. Investigation, we do electrophysiology, electroretinogram to diagnose the retinitis pigmentosa with electrophysiologic tests. Genetic counseling may be done. Also, it may be associated, retinitis pigmentosa, with other systemic manifestation, like in Usher syndrome, where there is deafness and retinitis pigmentosa. Management, management of associated problems like cataract removal, macular edema treatment with acetazolamide, low vision aids, genetic counseling to discuss the condition with the parents and the patient. The next dystrophy is called cone dystrophy. It is dystrophy in the cones in the region of the macular area. And next we have the juvenile macular dystrophy, which is a variety of inherited condition that affect retinal pigment epithelium and photoreceptors. All are rare conditions, including one of them, Stargardt's dystrophy, in which there is poor vision, central and poor central vision, and social and educational needs of the patient should be assessed, and genetic counseling should be offered. Low vision aids, there is no specific treatment for these macular dystrophies. Stargardt's macular dystrophy. The next subject is albinism, which is defective melanin synthesis, and these have 2 main types, ocular albinism and oculocutaneous albinism. Ocular albinism, lack of pigmentation confined to the eye, and there are X-linked or recessive forms of this ocular albinism. Oculocutaneous albinism, there is white and or pale skin, loss of pigment melanin in the skin and in the eye. In the eye, we will see trans-illumination through the iris, where there is loss of iris pigment. We will see the red reflex through the pupil and through the iris. We will have nystagmus, foveal atrophy may be present. These patients may have abnormal projection of retinal axons to the lateral geniculate body. Some of these patients with oculocutaneous albinism may have systemic association as Hermansky-Pudlak syndrome, where there is hemorrhagic diastasis associated with oculocutaneous albinism. So we should be careful if we decided to do surgery for these patients, like strabismus surgery or any other type of surgery. we should be careful about the hemorrhagic diastasis that may occur. Next subject is the retinal tumors. We have retinoblastoma, which is the commonest malignant tumor of the eye in children. Frequency 1 in 20,000 live births, and it may be inherited as an autosomal dominant. It may be sporadic. It may be associated with germinal mutation passed to the next generation, or it may occur with somatic mutation affecting single retinal cell and cannot be genetically transmitted. Retinoblastoma gene was discovered, and it is thought that a mutation, homozygous defect, should occur in a pair of these genes to develop the disease. What are the history and symptoms of a child with a retinoblastoma? Usually these children are affected around the age of 8 months. From birth to 25 months also we may see sporadic cases. The symptoms usually they present with leukocoria, which is whitish discoloration of the pupil. The mother will notice whitish discoloration of the pupil, which we call leukocoria, due to the presence of the tumor in the posterior segment of the globe. Squint is the second mode of presentation due to reduced vision, red painful eye in advanced cases where the tumor is very big. Most cases present by the age of 2. Inherited retinoblastoma is often bilateral. So a case of bilateral retinoblastoma, we should think, we should suspect that it is an inherited form, not a sporadic form. When the condition is unilateral or presenting on presentation and there is no family history, inherited disease is less likely. يبقى unilateral condition less likely to be inherited, but not excluded. Signs: we will see a whitish pink mass during fundus examination, filling the vitreous cavity and infiltrating the retina. We can do investigations in the form of CT scan to detect the mass, to detect calcification. We can do ultrasonography detecting the mass and calcification. CSF fluid examination, bone marrow examination also can be done. Treatment: if the tumor is big, filling the eye, and there is no hope of recovery of this eye, we do removal of the eye, enucleation. Radiotherapy may be done. Cryotherapy may be done in anterior small tumors. Photocoagulation can be done with laser in posterior small tumors. But if there is metastasis, these children should have chemotherapy, and then we will deal with the eye either by enucleation or other modes of treatment. Genetic counseling should be done. Prognosis depends on the unilaterality, bilaterality, severity, size of the tumor, the presence of metastasis. Overall mortality of this condition is 15%. About 50% of these children, with germinal mutation, unfortunately will develop a second primary tumor as osteosarcoma, for example, of the femur. Or they may develop a tumor, other malignant tumor that is related to the radiotherapy, usually in the orbital region. Next masses that or tumors that we see in the fundus is astrocytoma, which is a tumor in the retina and optic nerve, seen in cases of tuberous sclerosis and neurofibromatosis. Usually as a white berry-like lesion, seldom symptomatic and requires no treatment. Its importance is that it is part of the diagnosis of some systemic diseases, as we said, like neurofibromatosis and tuberous sclerosis. We will shift to the choroidal tumors. Choroidal tumors arising from the choroid are seen in the fundus as pigmented lesion, and so the differential diagnosis of a pigmented lesion should be discussed. Pigmented lesions of the fundus may include retinal pigment hypertrophy, which is localized, non-elevated pigmented areas of the fundus, or areas of previous chorioretinitis, multiple scars in the fundus with a patient history of uveitis and chorioretinitis, and these scars are pigmented, choroidal nevi, and the rarest cause, which is malignant melanoma. Malignant melanoma is a part of uveal melanoma. It is seen very much more commonly in white rather than in non-white races. It usually presents in the old age, in the middle and old ages from 40 to 70 years of age. Malignant melanoma may occur also in the ciliary body and may occur in the iris. By far the greatest number, 80%, are found in the choroid. Symptoms of malignant melanoma of the choroid: loss of visual acuity, visual field defect, but sometimes it is discovered, but mostly it is discovered accidentally, because it usually occurs in an area away from the central posterior pole. If it is situated in the anterior part of the choroid, enlargement of the tumor will push the iris lens diaphragm forwards, producing shallowing of the anterior chamber and secondary angle closure glaucoma. The signs of malignant melanoma include raised pigmented lesion in the fundus. It may be associated with retinal detachment and optic nerve involvement. Investigations: we do systemic اللي هو we do investigations to exclude systemic spread like CT scan and MRI. We may take also we may do ultrasonography. Treatment: number of therapies are available, and the treatment depend on the size and location of the tumors. Large tumors may require removal of the eye, enucleation. Small tumors may be treated with localized excision, localized irradiation, or which is radiotherapy or radiotherapeutic plaques, which is metal plaques with a radioactive substance that is sutured to the surface of the sclera from outside, overlying the tumor area, and this is called brachytherapy, or by radiation with proton beam irradiation. Prognosis depends very much on the type of the tumor, location of the tumor, and the presence of metastasis. Spread may occur to different parts of the body. In women, the commonest side of spread we have the last subject, which is metastatic tumors of the choroid. Metastatic tumors of the choroid. Metastatic tumors, they account for a great part of ocular malignant diseases. In females, the commonest site of spread is from the breast. In men, from the bronchial carcinoma. Signs and symptoms of metastatic choroidal tumors will depend on the site of the metastasis in the eye, posteriorly or anteriorly. Usually it is a whitish lesion, little elevated, may be associated with retinal detachment, and the treatment is treatment according to the systemic condition, whether with chemotherapy or external beam irradiation. شكرا. خلصنا يمكن احنا.